we have our very own Dr. Timothy Lesser joining us for prostate cancer interview. So thank you for taking the time to hang out with us. So a little bit about you, Tim. You're a South Bay native, correct? Grew up in Manhattan Beach, and you attended medical school at USC and completed your urology residency at Kaiser Permanente LA under the legendary Dr. John Caswick.
That's right.
Yes. Awesome. And then currently you're the chief of urology at Providence Little Company of Mary and Torrance.
That's correct.
And you practice at South Bay Urology here in Torrance downstairs.
That's correct. Also, all correct. Yes.
So to kind of get started about prostate cancer, we're just hoping if you can kind of give us a quick overview of diagnosing prostate cancer, right? Like how that comes about when a patient comes to you for a consult. Do they already kind of know that that's where they're geared toward from a primary care, or is it more of a routine check-in that PSA levels change, or a digital rectal exam is done and you find something of like a mass or something like that?
Or all of the above, actually. The last thing you described, where we find like a nodule or a mass on the prostate, is pretty rare nowadays. PSA is, though not perfect, it's sensitive. But very often, the sort of typically we will have a patient referred for elevated PSA, and very often, the primary cares are actually pretty savvy now. It used to be, one elevated PSA and they'd send them over, and then we'd sort of take it from there. But nowadays, the primary cares will often like double check it, double check and make sure there's no other symptoms, for example, that would cause an elevated PSA, like an infection symptoms. Make sure they're not avid bike riders. Guys that are road bikers can often have a falsely elevated PSA. All of it's sort of geared toward the PSA not being a perfect test. So we try to kind of get rid of the things that might cause imperfections. And then they'll see me. I'll go through sort of a diagnostic process where, I will confirm that the PSA is elevated very often, check the prostate myself, make sure there's no nodules. And then what I do very often now is get an MRI of the prostate, which is sort of akin to a mammogram. Identifies any lesions within the prostate. And if there are lesions, and we actually have software that's able to target those lesions with a biopsy, should it be needed.
Wow.
So that's typically it.
So now, is the MRI done following the consult with you, or do you generally have them prior?
After the consult, the consult, And it's sometimes it's a rigmarole to get it through the insurance, because the data, as like many things, right? Because the data, oftentimes insurance companies lag maybe like 2-3 years behind the data, and there is some controversy to use of MRI. It's not, not everyone does it, but I'm definitely a strong believer in it, based on the data that I've seen and certain clinical application of it for sure.
Got it. That's good to know that the MRIs are being done. So talking a little bit about malignancies of prostate cancer, right, as well as if someone is just having or is having BPH or something of that nature, the symptoms sometimes resonate on each other, of like the urgency, the frequency, and stuff like that. Now, will you have elevated PSA levels if it is benign, or if they're having other issues?
Well, I mean, I think there's a few sort of points there. The most common cause for elevated PSA is actually prostates just getting bigger, which happens to guys as we age. Prostates tend to get larger. So there's like almost like a linear correlation well, not always, but between age and PSA. We expect PSAs to be of a higher value. In fact, there are sort of age-adjusted norms for the PSA levels. And then you sort of touched on the symptom part of it. I tell patients all the time, the most common symptom for prostate cancer is actually no symptoms, because it's really rare that prostate cancer, causes an obstructive process.
Gotcha.
Right. So in benign prostate, I have like all this. I always use like visual stuff, but benign enlargement of the prostate typically happens around the urethra. And so there's an obstructive process that happens, whereas prostate cancer, something like 70 to 80% of prostate cancer, whoops, I threw a stat out. I'm not supposed to
say.
Come from the periphery of the periphery of the gland. And so the urethra is in the middle of it. So it is pretty rare that prostate cancer causes symptoms.
Good to know. Now, what about if the cancer has now metastasized, right? I know the biggest metastases comes through when you get bone mets. So with that said, is surgery on the table, off the table? Like, how is that kind of decided?
Very rare, very, very rare that we do surgery if it's already spread. So unfortunately, a number of years ago, 2012, by memory, the United States Preventive Service Task Force came up with a recommendation against using PSA screenings. And all urologists sort of knew, the writing was on the wall, and we saw it in clinical practice that a lot of patients would then present when it had already spread, unfortunately, because of PSA. Now, thankfully, since then, they have sort of, reevaluated that, and they retracted it and said, you need to discuss with your doctor whether PSA is good. So anyway, urologists know that PSA is not perfect, but we use it appropriately generally, which is good. But I think the symptoms of spread, to answer your question, once it's already spread, it's very rare that we do surgery. It's only if you cause, and this is true of most cancers, we call it a palliative surgery at that point, because you're not curing them of anything, but you're just treating the symptoms. So if it is locally advanced prostate cancer to the point where there are causing symptoms, which is pretty advanced prostate cancer, then rarely would we do a surgery, but we can do it sometimes. If it's already in the bones, which is the most common place to spread, almost never do surgery, very rare.
And then I guess a question from our chat is, what are the most recent recommendations on when to use PSA levels?
So interesting. So this is I can answer this in like an hour, but I think I'll do a shortened version. So the recent, it depends on who you ask, right? There's different organizations that say different things. The American Urologic Association, oh geez, man, now I'm gonna have to get this correct, because I'll tell you how I feel on at the end. I believe they say after age 70, it's a discussion with your doctor. In fact, everyone says it's always a discussion with your doctor, right, because their liability or who knows what. But the current recommendations that sort of I go by, and this was the European recommendations by memory, are that you need to look at the longevity of the patient. See, the key to prostate cancer screening is you don't want to miss highly aggressive disease, but even highly aggressive disease, not as a rule, but generally, you still have many, many years to live, even with highly aggressive prostate cancer. So if someone's going to live, and of course, no one has a crystal ball, but generally, like if someone has 10 years to live, 10 years plus, then I actually, I still screen for PSA. There are aggressive variant, aggressive, I don't want to say the variant word, but yes, there's variants of prostate cancer that can be quite aggressive, even diagnosed late 70s, early 80s, and they can, be so aggressive that they can cause, morbidity and mortality. But you have to be, careful. You have to use PSA appropriately. A slightly elevated PSA in a 79-year-old, you don't get all excited like we used to. You check again. The whole goal again is not missing that high risk prostate cancer. So.
Got it. And then now, is it fair to say there's that wait and watch period of like, okay, PSA is here, it's a little off, you can do the MRI, or there's other screening tools that you use in conjunction with your PSA?
Sure. Yeah. Trending the PSA is one thing, because we expect it to go up like this, and if you trend it out and it's going up like this, then it makes you a little more concerned. And as you said, there's MRI, which sometimes can be used as, okay, we're not missing anything terrible, well, let's trend the PSA. And then there's other scores, like the 4 other tests, I should say, like the 4K score, which can be helpful. There's ExoDx, which there's a lot of genetic markers that we use nowadays that can be helpful in determining whether there's something worrisome in there. At this point, though, even though it's not perfect, PSA is the sort of, I think of it as like the gatekeeper to the other tests, and the prostate exam, of course, too.
Got it. Now, so talking about most common, let's just say surgical procedures, right? We talk about radical prostatectomy, open versus laparoscopic or robotic assisted. I know that a lot of people, or a lot of urologists and neurosurgeons, have switched to more laparoscopic and minimally invasive surgeries. When are open radical prostatectomies warranted?
I'm going to be completely biased. I don't know that there's any reason to do open prostatectomies anymore. there's going to be an open prostatectomy surgeon out there who's going to be like, what? But I think I'm just thinking of Pete Carroll. He's a urologist up in University of UCSF. He's like world renowned, and he did thousands and thousands of opens, and then he did thousands and thousands of robotic cases. And when robotic is a laparoscopic procedure that's also you use a robot as part of it, and there isn't tactile feedback. So in other words, you're doing everything by visual cues and visual identification of planes and whatnot. And so the big all the open surgeons would say, you don't have that tactile feedback. You need that to know. And he said, he used some interesting words in some of the conferences to say that, but he basically said, no, there's no difference. that you don't gain anything. In fact, it's much more morbid procedure to do it open. So, at this point, at least in my mind, I mean, certainly there's no reason to do an open radical prostatectomy.
So safe to say majority of the surgeries that you perform are minimally invasive, laparoscopic, robotic assisted?
Very much. I mean, with respect to prostate cancer, yes, definitely. Absolutely.
Now with, could you explain a little bit about like nerve sparing, kind of in layman's terms? I think patients come into us and they're like, well, my surgeon said they did a lot of nerve sparing stuff and sensation's still a little off or whatever it is. And I'm kind of like, okay, well, could you explain a little bit about like what nerve sparing means when you perform these surgeries?
Absolutely. Yeah. So this was, it used to be back in the day historically, that whenever people had historically it was open prostatectomies, open radical prostatectomies. And it used to be basically, once you get that done, then you can never get it up again. You never get an erection again, because they thought the nerves were basically intrinsic to the prostate. And then there's a famous urologist from Johns Hopkins named Pat Walsh who did some pathologic anatomic studies, and they actually discovered that the nerves for erections are just barely outside in a very, very delicate tissue layer outside the prostate. When I explain it to patients, I always say, think of the prostate like an orange. Prostate has a capsule on it like an orange peel. If you wrap that orange in saran wrap, that's where your nerves are, in that tiny little layer of saran wrap. So I think there's sort of a misunderstanding that you actually identify and visualize the nerves. You don't. You are able to identify the capsule of the prostate, and then the very subtle plane that's between the capsule and that layer of saran wrap. That's what you kind of identify. And as you get more experience, you're able to identify that with more expertise, I suppose. And then sort of conceptually speaking, when you're doing the dissection, it's sort of like, instead of dissecting the nerves away from the prostate, you're dissecting the prostate away from the nerves. You don't want to disrupt, the less traction and the less trauma to the nerves, the better. So, but the other thing I would tell patients is, I mean, you can do what you think is the best nerve sparing operation ever. I can't believe this guy's going to have amazing erections, and he'll, it'll be a long delay until he gets it back. And other times you're like, man, that was a really difficult one, a lot of inflammation, and he gets erections back right away. So it's a little bit unpredictable in terms of how things respond, to it. So.
Yeah, and then I guess along those lines, when I generally have a patient pre-op or post-op for prostatectomies, I usually tell them most of the time doctors will prescribe a very low dose Cialis or something of that nature. And I usually tell them it's not for the erection, it's for the blood flow. Can we agree on that? Is there kind of
Yeah, but it's, these are guys. It's always all about the erection. You understand that. But yeah. So one of the theories as to why guys get long-term erection problems afterwards is you sort of lose that daily cycle of getting erections. Getting oxygenated blood to the penile tissue, we call it the corporal bodies. And so the idea of taking a Cialis or Viagra or whatever every day is to bring that oxygenated blood in there to avoid scarring and fibrosis in the shaft of the penis that might prevent the erections from returning.
That is very good to know. Now, another question from the chat: any association with history of cardiovascular health and ED?
Oh, for sure. Yeah. I mean, the arteries that feed the penis are tiny little arteries, and they need to be elastic. So when you're 20, they go from this big to this big without a problem, probably when you don't want it to happen. But in any case, as you age, your arteries become more sort of like lead pipes, if that makes any sense. So they lose that elasticity. And, true. There's very much correlation between cardiovascular disease and erectile issues as well.
So are there any criterias for like lifestyle changes and like smoking cessations and stuff like that prior to surgery?
Oh, that would be nice. Yeah. I mean, but but it would be nice to wave a wand and have all people stop smoking. I mean, there's nothing that's going to prevent them from having surgery. But definitely that's a discussion that is had prior to surgery. The healthy you are going in, certainly the healthy you are will be coming out. There's a chance for getting erections coming out and stuff. Yeah.
No. Now, I think something else we talked about is lymph nodes, right? So are lymph nodes generally removed during prostatectomy, or is it only if there's a high chance of metastases or something of that nature?
So yeah, I mean, it's pretty rare that we do prostate cancer surgery when there isn't a chance for spread. For a lot of prostate cancer that we diagnose nowadays, it's kind of a low risk prostate. Well, not a lot of it, but a certain percentage of it is going to be low risk prostate cancer. And there's very good data that you are very safe to monitor low risk prostate cancer patients. So we call it active surveillance, where you just monitor and put them on a protocol of checking PSAs and redoing the biopsies every so often. But for intermediate and high risk prostate cancer, it is indicated to do a lymph node dissection. Intermediate, it's a little bit arguable depending on how the volume of disease, et cetera. But almost always now, if I'm taking a patient for a prostatectomy, I'll do a lymph node dissection if they're in their intermediate and high risk category, which most of them are anyway too. Now there are very few side effects to doing a lymph node dissection. There are potential side effects, so it's a cost benefit that you always talk about with the patient ahead of time, but the side effects are pretty rare and certainly worth it as a staging procedure.
Got it. Any incidents of lower extremity lymphedema when you do lymph node dissection?
Yeah, it's like 5%. And that's one of the main ones that people complain about. And there's lymphedema clinics actually that specialize in that for one thing. And then very often it'll take care of itself, with some time. And it depends on lymph node dissection to some extent as well. That there's a larger template, sort of template of lymph node dissections that we take out. And so with a larger template, if there's a higher risk cancer, there's going to be a little more chance for the lymphedema. But yeah, it's around 5% across the board. Yeah.
Second stat you threw in today. Good to know.
No, I got to stop that. Someone's going to.
Now, catheter. I think that's also something a lot of our male patients come in and go, well, it's cath for 7 days, and sometimes it could be up to 2 weeks. Now, where do you draw the line there as to like how long someone is cath for, and when is a good time for removal?
Yeah, a week. I mean, some people are doing it shorter. I do a week. It used to be like with the opens, they would do like 3 weeks, 21 days. It's, if you take it out too soon, there's a little bit more of a risk for a bladder neck contracture, a lot of people believe, which is a scarring at the bladder neck. So 7 days, seems to be that sort of nice balance between long enough and not too long. Long enough to avoid the bladder neck contracture, but not too long that you're, just torturing a patient. Right.
And then I guess following catheter removal, is there any bladder program that you guys put them on prior, or do you take the Foley out and do the plug? Like, where does the bladder retraining start?
So no, we just send them up to you guys. So no, we take out the catheter in the morning. So day 7 or sometimes day 6 or 7, depends on the day, when the day of the operation is. And we just take it out first thing in the morning. And 1 out of 50 patients, actually, they can't urinate. So we always take, we have come back to our office if you can't urinate, because we want to be the ones to put the catheter back in. Then in that case, we keep it in for a separate week, because that's inflammation at the what we call the anastomosis, where we put together the bladder with the urethra. And that usually, settles down over the next week, and never been a problem taking out a catheter the second time. But the other 49, the other 98% of patients, we take it out, and it's it's really quite variable. About 25% of patients have pretty good control almost immediately. 75% of patients will have some amount of leakage. With robotic surgery, you have a lot more precision, and so you can really preserve a lot of the bladder neck musculature without compromising cancer control. And that bladder neck musculature, as well as the pelvic floor musculature, is what men are going to depend on when their prostate's out, for their urinary control. And so of that remaining 75%, the great majority will get their control back. I mean, you guys have seen it within 6 weeks to 3 months. Every day that a guy leaks is a day too long. So it's, a lot of it's sort of pre-operative counseling of like what, hopefully you're in the 25%, but if you're not, it's going to get better. You just got to work on your exercises. I'm sure I'm sort of stepping on some of your questions in the future, but I always tell patients it's like you're going to a gym. You start off kind of wimpy and stuff, and then you go every day diligently going, and when your muscles get strong enough so that just the tonic, the word, whatever it is, like however strong they are, just in their resting state is going to be enough to hold the urine in the bladder.
Yeah, so a lot of the times, I think we've gotten a decent amount of patients pre-op. And I think sometimes it's hard too because of, like you said, insurance purposes, time of day, and then like when surgery is scheduled for. But the men that we do get in for pre-op, we can go over, the bed mobility transfers, how not to hold your breath so you don't get increased leakage, and understanding, pelvic floor strength and all of that. We see a lot better results post-op when you send them back up here, in the sense of they kind of know what they need to feel. And a lot of the times I'll have a couple of people look at me and go, oh, because I anatomically I call them the boys, and I tell them, okay, lift the boys, stop the flow of urine. Can you feel that? They do pre-op. They come back to me post-op and they go, can't find them. Right. And I'm like, okay, we'll give it some time. There's a little bit of swelling, localized swelling, and all of those things. Yeah. But we see that trend is if we get them post-op, pre-op, they generally do much better, and we do a shorter duration, and they have more continence and more control earlier on. But like you said, the way I describe it is you had a stopper around your bladder for however long you've lived, and all of a sudden the stopper gets removed and you have extra room here that all these muscles, like you said, are a little wimpy. They've never had to wrap around something a little bit tighter. Sure. And that's what we're looking for and hoping to find. Now, with that said, though, how many instances do you see that incontinence doesn't change?
So it's, yeah, I mean, no change at all is really rare. I mean, really, really, really rare. The time we see that seems to have the most delayed effect is when we have to do a bladder neck reconstruction. So what that means is, as I was saying, we try to preserve that bladder neck musculature as it sort of funnels down into the bladder. But sometimes people have certain prostatic anatomy, like larger prostates, and certain anatomy, like something called a median lobe, where we can't really preserve, we do our best, but it's just very difficult to preserve as much musculature. In which case you end up with like a very open bladder neck that you have to taper down to a urethra that's this size. So you can't just stitch it like that, of course. So we do a little reconstruction on the bladder neck. And because you're not dependent on those muscles, you don't have those bladder neck muscles, those people are even more dependent on building up the pelvic floor musculature that you help them with. And so it tends to be a little bit more delayed return of continence in those guys.
That's good to know.
One more thing is age. Age as well. I mean, definitely there's a correlation between recovery of continence and age. We just get, our muscles don't work as well as we get older, I think.
That's fair. But I'm not gonna lie. A couple patients that we've seen from you in their like 70s that are more active.
Oh yeah.
They kind of get it back fairly quickly.
Yeah.
Sometimes I'm amazed because I'm like, I didn't do anything. We just kind of taught the coordination. You understood what you needed to do, and the compliance is higher, and they do fairly well. So yeah, I think age is a factor, but I think it also depends on, again, like activity level.
Yeah, definitely. I think also mentally, I think the as you alluded to a second ago was anticipating when the leakage is happening. That's a lot of the education you must do, that you guys do with them is anticipating when the leakage is going to happen. When you get up from the chair, squeeze ahead of time, get it squeezed so to hold it in there. And it's really that part of it is really going to be kind of the last hurdle for guys, and getting leak control.
Definitely, and kind of talking down those lines of like the mental stamina for that is also, we all go 0 to 100. And the hard part is teaching someone you don't need 100 if you're getting up from a chair versus if you are lifting 50 pounds. So understanding that coordination, I think sometimes is a little hard of the hurdle as well.
Yeah.
Now, so let's talk about treatment following surgery, right? So I know there's a couple things that like radiation, hormone therapy, chemotherapy. when are those warranted, and how does that kind of play into post-surgical care?
So hopefully they're never warranted. That's the goal of surgery is to cure. Now with all cancers, including prostate, there is, you know, a certain percentage of patients won't be cured. And a lot of that depends on preoperative, you know, Gleason scores and volume of cancer and all that kind of stuff. But the idea with these adjuvant, we call it adjuvant, meaning after the surgery type treatments, is in some cases to cure, and in other cases to palliate. Palliate meaning not cure, but just, you know, hold things at bay. The curative, after the prostate is removed, the only curative modality is actually radiation. And typically that happens when you take out the prostate, but there's evidence that the cancer has moved outside the prostate capsule. Think of the orange and the orange peel. It's outside the orange peel. So in that case, sort of, there are certain criteria where we say, okay, we're going to radiate that area, including the pelvis, you know, basically that area of the pelvis, hoping to get any prostate cancer cells that may be in that area. So that can happen immediately postoperatively, or it can happen years down the line, when months to years, where the PSA is 0, which is where it should be, you know, after you remove a prostate, and then the PSA starts going up, meaning there's prostate cancer somewhere in the body. Generally with there's a lot of different parameters, but you know, we go with radiation sometimes in that scenario. Now the as you said, chemotherapy and hormonal manipulation is given in other criteria when the prostate cancer is either spread elsewhere, or if the PSA is going up despite our curative therapies. If the PSA continues to go up, then we know there's cancer somewhere else in the body. I always tell patients, you know, PSA is a perfect test for after the prostate's removed, because there's just nothing else in the body that makes PSA.
Right.
So it's perfect for that. So if you're being followed and the PSA goes up, then you got prostate cancer somewhere after the prostate's removed. So anyway, the hormonal treatments we do are called, one of them is called Lupron, and there's other ones called like Firmagon and some others. But those typically, all of them are aimed at reducing testosterone levels. So testosterone being the male hormone that kind of gives us our mojo. We have medical ways of decreasing that testosterone level, and thereby kind of shrinking back the prostate cancer wherever it might be. Testosterone is sort of the food for prostate cancer, so it helps. So that helps with that.
So now I know Lupron's kind of the big drug that is used for hormone therapy, but now what about the testosterone that is made in the adrenal glands, as well as like use of estrogen or something of that nature? Like when is that?
A good question. The way Lupron works is that it feeds back on the pituitary gland and tells the pituitary, hey, stop telling the testicles to make testosterone, which it does. But as you said, there's other ways that testosterone is made in the body, and so there's other medications beyond like the Luprons and the Firmagons and other medications in that category. There's going to be a rep who's mad at me for not saying the one that I don't use, but anyway, they target testosterone both from the testicles and from the adrenal glands. Erleada is one, Zytiga, Xtandi. These are all sort of very, very new medications that are very effective in holding back prostate cancer, not curing it, but holding back prostate cancer for a certain amount of time, average being 18 to 24 months. But they're really fantastic because they work on the cellular level, and they also work on like even in the nucleus. They're really, really amazing medications for blocking the role of testosterone in prostate cancer.
Okay, and then I guess the question in the chat is, what is the long-term success of Lupron, and what are the options to surgically remove testicles or have like an orchiectomy, I guess?
Good, really good question. So Lupron's very expensive. So in my father-in-law is a urologist, was a urologist in India, which he was here. But anyway, he said they don't really use Lupron there. They just do bilateral orchiectomies in all patients who have metastatic prostate cancer. It's very effective. There's no testosterone produced, so it works as well. I've had one patient here who said, I don't want to do Lupron. I'd rather have you take my testicles, remove my testicles. So there's one. And so that was like, gosh, how many years ago, and he's doing great. Anyway, so sorry, I think the question was 18 to 20, how long does Lupron last? Lupron has an average response rate once prostate cancer spread of 18 to 24 months. So PSA response rate. In fact, 18 to 24 months seems to be sort of like the magic number with all of these. But there's a huge tail. I have patients that are 10 to 15 years out, still having a great response to Lupron. So still have zero on the PSA and doing well and stuff. So yeah, it just depends.
And what would be the, I guess, next line of defense if Lupron does taper off and it doesn't hold back your PSA levels at 0?
That's when you add those other. No, that's when you add those other, the early autos and the Zytigas and the Standees, and then there seems to be newer modalities coming out all the time. So there's another one called Provenge, and there's then there's chemotherapy as well. That's kind of the algorithm that you go down.
Okay. And then what is the rate of ED with orchiectomies? If you have no testosterone being to supply the body.
I always tell patients testosterone is like the fuel for the car, but it doesn't mean the car is going to run. But if you take away the fuel, the car usually doesn't run. So usually one of my patients said, I don't really have erection problems, but I don't care that I don't have erection. I mean, my erections aren't working that well, but I seem not to care that much that my erections aren't working that well. Because Lupron, I should say testosterone drives your libido.
Right.
So you don't really have the desire there, and it's pretty rare that the erections work. I mean, there are guys who have, their testosterone is 3, and the normal being like 300s to 800 or 900, depending on which lab. But their testosterone is 3, and they still have erections. So God bless those guys. But but most guys don't get. I know, right? Nothing's going to hold him back.
Now, with the change in testosterone, right? So talking about like how physiologically it could change muscle and all of those things. Do you do a consult with them in the sense of like musculature will change a little bit because there isn't the driver of testosterone in the body?
Yeah, I mean, that's one of the things you talk about in terms of hormone. Whenever you do the hormone, initiate hormone manipulation is side effects. Just like any medication, you talk about side effects. So typically the ones for hormone is the hot flashes. It tends to be the most bothersome ones, and then fatigue and decreased muscle mass are the two other ones, as well as there can be bony issues as well. It can cause osteoporosis. So those are the 4 main ones you always touch on. And it's a lot of these guys are older guys, 70s or so, and so their muscle mass is decreasing anyway, so it's just it's a little bit more exaggerated. So but they know to expect it, and so it's a lot of it's sort of they actually keep on, depends on the guy, but I have a lot of motivated patients who are like, they're still going to the gym every day and still working out. They don't have quite the stamina they used to, but they still get it done,
And they want to maintain. Yeah, that's fantastic.
Right. Yeah.
So then once men go on Lupron, what's the recommendation for vitamin D or calcium and other things to preserve bone density, osteoporosis?
Daily. Yeah, daily dose vitamin D and calcium to decrease the chance for osteoporosis, and then also yearly DEXA scans to make sure if there is some osteopenia, meaning bone thinning or osteoporosis, where it's actually clinically relevant, then there's other medications that will actively put calcium back in bones that we have patients on. To decrease the chance of fractures or other potential pathology.
And then one question regarding kind of going back to surgery a little bit. I noticed with the laparoscopics, you have your ports around the abdominals, and then there's a abdominal incision, maybe about 2-3 inches, you would say. And so when you remove the prostate, that is where you pull it out from, correct?
Yep.
With that said, the different layers of like linea alba, rectus abdominis, and all the musculature that you have to cut through, do you see a higher chances of like a DRA, a diastasis recti abdominis, or anything like, or a hernia?
Jenny's watching me on this one. No, not at all. No, definitely not. Yes. Yeah. The answer is yes. Yeah. Some people actually take out the prostate from a lower midline. They do like a little mini fan and steel just above the pubic bone because of that. The rectus tend to be a little bit more robust down in the lower abdomen. The weakest point is going to be around the umbilicus, around the belly button. So that's exactly where we do. Now, I will say though, after the beginning of Dr. Matsunaga and my career here, we had a fair number of diastasis and hernias as well. So we brought in a general surgeon and we showed him how we were closing it. And so he actually showed us a few sort of tricks and different sutures to use. And I think our rates, Jenny, you can chime in if you want, but our rates have definitely gone down, I would certainly say, in the last, like 3 to 5 years, I would say.
Yeah, that's good to know, because it's something in PT that's also what we screen for. And I think a lot of patients come in, they're like, okay, so what are we doing other than the pelvic floor stuff? So talking about intra-abdominal pressure management, making sure they don't blow through any stitches,
Right.
internally or externally, as well as helping with leakage, because I don't think a lot of people understand, like, if you hold your breath and there's a path of least resistance from a strength and physical demand perspective, that functionally you will have some leakage.
Can you guys, Jenny, can you hear Linda? Can you guys hear me? Can you hear me, Linda? I can't hear you for some reason. My internet connection, saying my internet connection is unstable. So hold on a second. So
Tim,
sorry.
we can hear you now. Everybody went silent for me for about 15 seconds, but now it seems to be on.
Okay. Linda, are you back? I can't hear
Nope.
Linda. Can
Nope,
you, Jen?
Linda, I can't hear you either. Yep. You can jump in my office, Linda, if you want. It's gonna be one of those days. Okay.
Whoa, Linda, you changed clothes.
I think she's gonna slide right in here on mine.
Okay. She's gonna become Jenny.
Yep. Oh, that means I can't put any more comments. I love that you had a general surgeon.
Oh yeah. Yeah, definitely. Well, if you can't learn from your mistakes, I mean, I think that's an important part of practicing medicine. That's why they call it practice, right?
Yes, very true. All right, Linda's just down the hall, so.
You had a question that came across a second ago. I saw in the bottom, or maybe Steve had it or someone.
Oh, what percent of docs, I've got friends on the East Coast that actually I had asked if they were seeing a lot of the diastasis in the supraumbilical incision, and they said no, because they weren't doing one. Now, I don't think they were doing a mini fan and steel. That's really interesting. I haven't seen that.
Right.
I think they were morselizing the prostate
Right.
and pulling it out the portals. And
Yeah.
to me, that kind of freaks me out. I want all of that out, but I just didn't know how common that was.
So yeah, what they do when they morcellate is they keep it within a big plastic bag, like a little mini hefty bag, not big, a little mini, like a little plastic, and you actually just kind of, morcellate is a fancy term for you basically rip out the pieces of it through the port, and so the port ends up being this big, so less chance for hernia and whatnot. You lose your pathologic information when you do that, so you don't know if it went into the seminal vesicles. You can identify that, but that's a little tougher. You don't know if it's spread outside the capsule or outside the orange peel. So to me, I guess maybe I consider myself sort of an oncologic purist or whatever, but I want that information because it's gonna dictate my management, down the line. So, but there are a certain percentage of patients that say, look, PSA 0, it doesn't matter. As long as PSA 0, you're not going to do anything. So just follow the PSA, and if it goes up, then go for it.
Yeah. I think, yep, actually, that was the very last question that Linda had, and she said she lost her speaker. So I get to wrap it up with you.
Nice.
I did not see any other questions. So Gary and Steve, I know we've got a couple people on here live. If you have any last minute questions for us, feel free to throw them in the chat and we can answer those. So we really appreciate you sliding in here after surgery to hang out with us and talk about this. That was great.
Well, it's my pleasure. You guys do such a fantastic job with my patients. It's the least I can do. So
we really
it's nice because you make me look good. Keep my numbers, my incontinence numbers down. So I appreciate that very much.
Well, that's good. That's what we love doing. We appreciate being able to work with them as well. So Everyone, thank you very much for hanging out with us today. Funny when we were talking about lymphedema, Tim, I think you know Dr. Jay Granzow, and we interviewed him a couple weeks ago on breast cancer management. Next month, we're taking the month off because we are in the process of moving to our new clinic, but we would have been doing urologic cancer management, which we're going to pick up in August with Dr. Fik Atomdidi, who is a urogynecologist and a gyn-onc also here in Torrance. So we will be chatting about that, and you will hear about that then. All right, thank you very much for hanging out with us, and we will see you soon.